Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining us this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. According to the Center for Disease Control's 2022 National Diabetes Statistics Report, from 2001 to 2020, diabetes prevalence significantly increased among US adults 18 or older. 37.3 million people have diabetes. That's 11.3% of the US population. 28.7 million people have been diagnosed with diabetes. 8.5 million people who have diabetes have not been diagnosed, and they don't even know that they have it. And when it comes to prediabetes, 96 million US adults have prediabetes. 26.4 million adults, 65 or older, have prediabetes. But tonight, we are joined by Johns Hopkins endocrinologist Dr. Tom Donner, the director of the Johns Hopkins Diabetes Center, whose clinical and research interests have focused on the prevention of complications in patients with type 1 and 2 diabetes. So please use your Q&A on your screen to ask your questions to Dr. Donner, who will respond during the last 20 minutes of tonight's conversation. Our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. You can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. Donner.
Thank you, Kelly. So I suspect that those of you participating in this webinar come from a number of different backgrounds with a lot of different experiences with diabetes and knowledge about diabetes. So what I thought we'd do is start with the basics. What is diabetes? How is it diagnosed? Why is it important to diagnose? Can it be prevented? And then turn more into the management of diabetes. And my job tonight, hopefully, will be to provide you with the perspective of an endocrinologist or a diabetes specialist perspective on the management of diabetes and what's important. So let's start with the basics. So what is diabetes? So as many of you know, this is a blood sugar disease. And why is it a disease when sugar levels are elevated? Well, because sugar is a fuel for the body, isn't it? So it is the primary fuel for cells in the body to function and have energy. And for all organs of the body, including the brain. And it's only when blood sugar levels are elevated that it becomes a disease. And it becomes elevated because the sugar cannot get into the cells of the body and be used as energy. And that's actually one of the reasons why people who have high blood sugar levels tend to feel tired with diabetes, is because they're not getting their primary energy source delivered as effectively into the cells. And so it's a sugar disease. And when blood sugar levels are high, the higher the blood sugar levels and the longer the blood sugar levels are elevated, the more likely that complications from diabetes can occur. And the complications tend to be, that we are most concerned about, tend to be long-term complications. And these are blood vessel complications. So high blood sugar levels will cause changes in the lining of the tiny blood vessels going to the eyes, the kidneys, the nerves, that can ultimately damage them. And it can also lead to blockages in the blood vessels of the heart and the blood vessels going to the brain, leading to an increased risk of heart attack and strokes. Those processes tend to take many years to occur. So the importance of managing diabetes then is getting the blood sugar levels into a much healthier range so that we can ward off those complications from developing. The diagnosis of diabetes is pretty straightforward. We have very good diagnostic methods. The primary sugar in the bloodstream is called glucose. And when the fasting glucose level rises to higher than to 126 or higher, That's the threshold for being abnormal. Normal blood sugar level is 100 or less. If a random blood sugar, that means not necessarily fasting, is 200 or higher and associated with symptoms of diabetes, that's also diagnostic. So what symptoms are there of diabetes? And this is a little bit trickier of a question because there are many patients who have diabetes who really have no clear symptoms of their disease. When blood sugar levels can be in the diabetes range and no symptoms may be present at all. As I may have mentioned, tiredness can be a symptom, but tiredness can come from a lot of things. So it's not a specific symptom per se of diabetes. Once the blood sugar level gets above 180, the kidneys that filter the blood and hold on to important things like sugar, sugar is energy. So the kidneys tend to hold on to sugar. They can't, at a blood sugar level above 180, the kidneys can't hold on to sugar anymore, and sugar leaks in the urine. And you could detect it if you were testing sugar in the urine. And behind sugar in the urine draws water in. And so there's increased water output in people who have elevated blood sugar levels, leading to frequent urination. And that's frequent urination is a symptom of diabetes. And with frequent urination and water loss in the urine comes dehydration. And if your brain senses that you're dehydrated, you become thirsty and you drink more. And so frequent urination and increased thirst are the cornerstones of symptoms of diabetes. So if you have a random blood sugar level of 200 or higher, and those symptoms, that's diagnostic of diabetes. We also have an extremely useful test, which is called the hemoglobin A1C, that can be used to diagnose diabetes. Hemoglobin is present in red blood cells, and it's a protein in red blood cells that the higher the sugar level in the blood, the more sugar sticks onto hemoglobin, and so we call that glycohemoglobin. And elevated glycohemoglobin or elevated hemoglobin A1C, a level above 6.5% or higher, is diagnostic of diabetes. And that test is about a 3-month average blood sugar level. So it's a very useful test because somebody may have a normal fasting blood sugar level or a random spike in blood sugar level, but their average blood sugars overall are either elevated or normal. And so the hemoglobin A1C is a 3-month average. And so it averages out all the blood sugar fluctuations for the prior 3 months and gives us a very good picture of whether somebody has diabetes, number one. And then it's also the main marker that we use for whether a diabetes is being controlled or not, is the hemoglobin A1C value. Another less commonly used mode now, but more commonly in pregnancy, is the oral glucose tolerance test. So you can diagnose diabetes by drinking a 75-gram slurry of sugar, a sugar slurry basically. And if the 2-hour blood sugar level is over 200, that's also diagnostic of diabetes, but we tend not to use that anymore for diagnosis. So why is it important to diagnose diabetes? And Kelly mentioned something called prediabetes, and mentioned that up to a third of patients without diabetes don't know they have it. And that's a problem because, as I alluded to earlier, that the diabetes complications depend on how high is the blood sugar and for how long. And so if you don't know you have diabetes and the blood sugar levels are elevated, you may be developing complications from diabetes over time and not know it. And those complications can be irreversible. And so from our standpoint, we like to diagnose diabetes as early as we can so we can stop any development of diabetes complications at the onset. We know from past experience that up to a third of patients newly diagnosed with type 2 diabetes can have complications at diagnosis. I'll talk a little bit about the complications in a little bit. So it's also important to diagnose prediabetes, and prediabetes again is blood sugar levels that are mildly elevated, but not quite to the point of diabetes. We call it prediabetes because we really don't see diabetes complications at that blood sugar level, but it is a marker of a very high risk for developing diabetes in the future. And we know that there are very good interventions for preventing the onset of diabetes if you have prediabetes. And sometimes we can make prediabetes turn back into normal blood sugar levels with those interventions. And so that's useful for diagnostic purposes. The other important reason that it is to diagnose prediabetes is that there's an increased risk of heart disease if you have prediabetes. So why would that be if the diabetes small vessel complications aren't elevated? Well, people who have prediabetes and people who have diabetes tend to have a cluster of different things that put them at increased risk for heart disease. And that cluster includes not only elevated blood sugar levels, but also elevated blood pressure, elevated cholesterol levels, abnormal types of cholesterol, low good cholesterol, and overweight. And all of these place patients at increased risk for heart attack and strokes. And the American Diabetes recommendation is in persons who have prediabetes is to treat those other risk factors for heart disease aggressively. So we are more apt to treat patients more aggressively with blood pressure medications and cholesterol medications because the clock for heart disease starts ticking when people have prediabetes. So that's the important reason to try to diagnose diabetes earlier. And so we screen patients for diabetes. So recently, the recommendation came out that we should be screening every adult at age 35 or over with one of the different options for screening for diabetes. And if you are younger and overweight, or if you have a family member with type 1 diabetes, or are in an ethnic or racial group that has more predisposed to diabetes, those include African American, Asian American, Hispanic Americans, all of whom have higher rates of type 2 diabetes, we actually screen at an earlier age. There are two main types of diabetes, type 1 and type 2, and I'd like to just discuss them briefly and what the difference is. Type 1 diabetes is an autoimmune condition, and an autoimmune condition is one in which your immune system decides to attack and destroy the insulin-producing beta cells in the pancreas, which leads to insulin deficiency and a requirement for insulin therapy to essentially keep patients alive. It used to be called insulin-dependent diabetes in the past. Why does the immune system do that? We still do not know. It's a big question. There's definitely a genetic predisposition, especially Scandinavian countries, particularly in Finland, they have much higher rates than other parts of the world. But we don't know what the trigger is. A viral cause has been suspected for a long time. Many people report that months before their type 1 diabetes diagnosis, that they had a bad viral infection, but no one virus has been isolated. So there's a lot of research work being done, because if we can determine what the cause is, we can prevent the disease from coming on, and prevention is always better than having to treat a complicated disease like type 1 diabetes. Type 2 diabetes is much more common. So type 1 makes up about 5% of all diabetes, and type 2 about a little bit over 95% of diabetes is type 2, the much more prevalent disease. And that is the reason for the bulk of the increase in diabetes. So when I was training in medical school many years ago, 4% of the United States had diabetes. And as you just heard from Kelly, it's up to 11%. That's a huge increase in diabetes. Not just that we're screening people and diagnosing it more, that's a real increase. And why is that? Well, I want you to think about the environment that we live in today compared to the environment that we lived in the 60s and 70s. We now have computers, we now have iPhones, and we have TV sets. And that has made us inactive as a population, and we are considerably less active. You think about 3 generations ago, you had to farm and be physically active to stay alive. That's not the case anymore. Many of us have computer-based jobs, and we don't need to be physically active. And the other issue is that we have a lot of prepared high-calorie foods, and our diets are not the same. You know, our diets used to be things that grew out of the ground, and you would grow them, and you would harvest them, and you would cook them, and that's not the case anymore. We have a lot of prepared foods, and these have foods that are tasty, are high in sugar and high in fat, and so we are eating a much higher calorie diet as a whole, as a nation and as a world. And so rates of overweight and obesity have increased, and type 2 diabetes is tied into both physical inactivity and overweight. And so that's a primary driver for higher rates of type 2 diabetes. When I was training many years ago, initially, the cutoff for diabetes was age 40. If you were under age 40, you had type 1, and you were over age 40, you had type 2. That was that was blown out of the water decades ago. And we are now seeing children who have type 2 diabetes. These are typically children who are born of parents who have type 2 diabetes, who are relatively inactive and have put on extra weight. And so in those higher risk individuals, we actually are now recommending that they be screened for diabetes, whereas 40 years ago, we would not have been screening that patient population. So, so that's the reason why it's important to diagnose diabetes. What are the complications? And I've already mentioned some of them to you. These are blood vessel complications. And so the small blood vessels in the eyes, the kidneys, and the nerves are hallmarks of diabetes. And so diabetes can be a bad disease. And again, I'm going to be talking about some significant complications, all of which are preventable. But diabetes remains the leading cause of vision loss in adults. It remains the leading cause of kidney failure in adults. The leading cause of foot problems in adults is from diabetes. And it's a leading cause of heart disease. Again, these diabetes complications are preventable with good blood pressure control, good cholesterol control, and especially good diabetes control. If you have diabetes or prediabetes, you have an increased risk of heart disease, as I mentioned. The risk is twofold in men. So if you're a man with diabetes, your risk for heart attack or stroke is twofold that of someone your same age who's male who does not have diabetes. Women in general are protected against heart disease. That protection is eliminated if you develop diabetes. And so if you are female and have diabetes, your risk for heart attack or stroke is fourfold that of a woman without diabetes. And so I think you'll keep hearing cardiovascular disease as an underlying theme tonight, because when I see a patient, my job is to prevent them from having a heart attack or stroke through the means I just mentioned to you. So what kinds of things affect blood sugar levels on a daily basis? We talked about weight, and so weight gain in general tends to make the body less sensitive to insulin and raises blood sugar levels. And how does that happen? Well, weight is associated with increased percentage of body fat, and that fat gets into muscle, that fat gets into the liver, and it makes those organs less sensitive to insulin. And so when muscle becomes less sensitive to insulin, it's less apt to take sugar out of the bloodstream. And when the liver has more fat containing in the liver cells, it tends to produce more sugar. Usually the liver only produces sugar when the person hasn't eaten in a long time. And a person with diabetes, the liver, because it's not sensing insulin, it thinks you're starving all the time, and it makes more sugar. So that's one of the mechanisms where weight gain leads to higher blood sugar levels. Diet plays a large role in our ability to manage diabetes and for patients to manage their own diabetes. It's the carbohydrates that we eat, also known as starches, that get broken down into sugar. And those include bread, cereals, pasta, potato, rice, and fruits to some degree because they have natural sugars in them. And so one of our recommendations is to moderate carbohydrate intake. If you have 4 slices of pizza and you have diabetes, it's going to be hard, regardless of what medicine you're on, to prevent your blood sugar from spiking up high after eating that. So moderation of carbohydrates and moderation of simple foods containing simple sugars is important in the management of diabetes. The other lifestyle modification is physical activity. And so we try to get patients more physically active. And that's challenging because many of us, when we get busy, the first thing that goes out the wayside is physical activity, especially if we're doing sedentary jobs. So, but we really try to make it an important part of everyone's life to incorporate exercise into their daily routine. The recommendations is at least 30 minutes, at least 5 days a week, so 150 minutes per week of exercise. And where did that number come from? Well, years ago, they did a study called the Diabetes Prevention Program, where they took persons who were at very high risk for diabetes with prediabetes who were overweight, and they randomized them to no intervention, to physical activity and healthy lifestyle with a goal of a 7% weight loss. And the exercise was 30 minutes, at least 5 days a week. So that was the minimal amount of exercise. And the third group was metformin, which is a drug we use to treat type 2 diabetes that doesn't cause low blood sugar levels. So it's considered to be safe in people who have prediabetes. And they looked at outcomes over time. And then after 3 years, they found that lifestyle was the most effective way of preventing prediabetes to going to diabetes. And a large portion of those patients actually fell out of the prediabetes range. There was a 58% reduction in the development of diabetes in persons who had intensive lifestyle measurements. So that's a cornerstone of our treatment, whether you have prediabetes, whether you have diabetes, whether you're just overweight and want to prevent your blood sugar levels from ever going up. Nutrition and physical activity are extremely important. The metformin group also prevented progression from prediabetes to diabetes, but just not as effectively. That rate was about 38% reduction compared to not doing anything. So we do have ways of preventing diabetes from developing or even reversing mildly elevated blood sugars and getting people back into a good range. Another thing that affects blood sugar levels is stress. Both physical and psychological stress will raise blood sugar levels up. And why would that be? Well, when your body is stressed, it responds by making stress hormones, especially cortisol, glucagon, and other stress hormones. And in a time of stress, the body wants energy. And as I mentioned, sugar is energy. And so those hormones go to the liver and tell the liver, dump sugar in the bloodstream. And so when you're stressed, the liver makes more sugar and blood sugar levels go up if you have diabetes. If you don't have diabetes, the liver will make more sugar, but the pancreas makes more insulin, keeps blood sugars in a good range. So stress can raise blood sugar levels up. Another thing that can raise blood sugars are medications. Probably the most common medication that raises blood sugar levels are steroids. Steroids such as prednisone, which are used quite commonly. They're the most effective anti-inflammatory medications that are out there. So we use them to treat asthma exacerbations, for rheumatoid arthritis, other rheumatoid diseases. We inject steroids into joints that are swollen to try to reduce pain. And those steroids can come out of the joint and into the bloodstream and can raise blood sugar levels up. So drugs of those type are quite commonly raise blood sugar levels up. If you have had a transplant and need to be put on immunosuppressive medications to prevent the immune system from attacking and destroying the transplanted organ, blood sugar levels can go up. And medicines we use to treat HIV can make blood sugar levels go up. So those are things that can raise blood sugar levels in all people. So when diet and exercise alone don't do it, we have, fortunately, at our disposal many medications. And I think many of us would prefer not being on medications. And I am fine with patients trying lifestyle to get their blood sugar levels under control. But if serious attempts, especially after several months, do not improve blood sugar levels to a level where I know that complications are going to be quite low, I will be recommending to patients medications. And we have a number of our medications available to us today, and we target them in terms of what we want to do and what we want to prevent. If blood sugar levels are extremely high, we place patients on insulin right away because none of the medicines are going to work that well if blood sugar is extremely elevated. If they're mild to moderately high, we have a number of pills that are not insulin that either make the insulin work better, so that treats the insulin resistance, or that stimulates the pancreas to make more insulin itself and to help lower blood sugar levels. And there are once a day or once a week injectable medicines that act very much like a naturally occurring hormone made by your intestines when you eat food called GLP-1. These are called GLP-1 agonists because they act just like the naturally occurring hormone that work beautifully to not only control blood sugar levels, but also to regulate appetite. And these drugs are heavily advertised these days: Victoza, Trulicity, Ozempic, extremely effective. And that class of medications is one of the classes that also reduces cardiovascular risk. So years ago, a medication came out that for diabetes that led to an increased risk of heart attack and strokes. And when that happened, the Food and Drug Administration said, if you want to submit a new drug for approval, you need to do a 3-year cardiovascular trial that shows that there's no harm from a cardiovascular standpoint, since cardiovascular disease is so common in people with diabetes. And so all drugs these days need to do cardiovascular outcomes trials. The fortunate thing is that many of them have now been shown to reduce cardiovascular risk. And those include metformin, which has been around for 90 years or so, and studies have shown that long-term metformin use can reduce cardiovascular risk. This class that I just mentioned, the GLP-1 agonists that are once a day or once a week injections, 13 to 15% reduction in heart attack and stroke rates after just 3 years. So a convincing reduction in heart attack and stroke rates. Another class of medications called the SGLT2 inhibitors reduce cardiovascular risk, particularly heart failure, by that same 13, 15% amount. And those drugs work in an unusual way. They block the kidneys from holding on to sugar. That actually makes the kidneys lose sugar, and by losing sugar, you're losing calories, lowers blood sugar levels, and unexpectedly, from my standpoint, they reduce the risk for heart attack and for heart failure. And then another medicine that's older that has other side effects that also has been shown to reduce heart attack and stroke rates is Actos or pioglitazone. It's a medicine we don't use as much because it tends to lead to weight gain and a small increased cancer risk in the bladder. So since patients with diabetes have such a high risk for cardiovascular disease, I tend to use more of those drugs that reduce cardiovascular risk. And all those medications also tend to lead to weight loss as well. And this is persons with type 2 diabetes tend to be carrying carrying extra weight. And so weight loss is a benefit for them. I'm commonly asked, is there a cure for type 2 diabetes? And obviously not, otherwise 11.3% of the population would not have diabetes if we had a cure. The only cure is dramatic weight loss. And there's only one form of dramatic weight loss that is intentional, and that is bariatric surgery. And so bariatric surgery makes people lose 50 to 80% of their excess body weight. And among people who have type 2 diabetes who undergo bariatric surgery, 70% of them will have a remission of diabetes. It's not a cure per se, but their blood sugar levels fall back into the normal range. Should they regain weight in the future, their diabetes can come back. So we don't really say it's a cure, but patients will go into remission. There are some side effects for bariatric surgery, so that discussion needs to happen with a person's physician and bariatric surgery teams before somebody goes. We tend to reserve it for patients who are who are very overweight, who tend to have difficulty losing their weight. And but if again, that's the only intervention that we can do that's not medicinal, that will get blood sugar levels back into a normal range. In type 1 diabetes, where their pancreas is no longer making insulin, there's been a lot of hope that there would be a insulin cure of some sort. We have remarkable ways of insulin delivery now, including pumps and continuous glucose monitors that I'll talk about in a minute. But the only cure we have for type 1 diabetes right now is a pancreas transplant. So if you transplant an organ, a pancreas that starts functioning well after the transplant, it will start normalizing blood sugar levels, and but at the expense of needing immunosuppressive therapy, which has its side effects. So we do not routinely transplant every patient with type 1 diabetes. Typically, we only transplant them if they have had kidney failure, they need a kidney transplant. We will oftentimes recommend that they get a pancreas at the same time. They are on the same immunosuppressive medications, and they get rid of their diabetes. So that is another mode of therapy. Just briefly on type 1, discussion of type 1 therapy is complicated. I'll just give you a brief overview. We try to replace insulin in a physiologic manner, and that is extremely challenging. The human pancreas has a blood sugar meter built into it. And so if the blood sugar level becomes mildly elevated, a small amount of insulin will be released immediately. And that insulin lasts for 1 to 2 minutes and it's gone. And if you drink a 2-liter bottle of Coca-Cola, more insulin is made and the blood sugar stays normal. It's really remarkable. The blood sugar levels in people without diabetes stay in the 70 to 140 range all day, a very tight range. That's how closely blood sugars are managed by the body. To do that in the ways we have treating patients is challenging because the insulins that we use are subcutaneous. The most rapid acting insulins we use work 3 to 5 minutes after injected. Most of them work about 15 to 20 minutes. So we try to get patients to inject their insulins 3 to 5 minutes or 15 to 20 minutes before they eat. And that can sometimes be challenging. And especially if you have 5 minutes to eat, you can't wait 15 minutes. The other challenging part of type 1 diabetes is it's not just food that affects blood sugar levels, but stress levels will raise blood sugar levels up. And we don't have stress gauges that tell us, oh, I need to give myself insulin because I'm stressed right now, or physical activity will reduce insulin requirements. And so patients, to prevent a low blood sugar, need to either, if they're exercising after a meal, take a little bit less insulin before they exercise, or they need to eat to prevent a blood sugar from dropping with physical activity. So the best ways we have today, the most physiologic way, are insulin pumps that deliver rapid acting insulin through a continuous delivery system. Typically a small catheter is under the skin and continuously delivers rapid acting insulin. That rate can be adjusted on an hourly basis, how much they receive. So overnight, when their stress level is low, they can receive a very low amount of insulin. In the morning, when everybody's stress hormones go up, we can raise the amount of insulin they receive, and they can decrease the amount of insulin they get before they start exercising so they don't have a low blood sugar reaction. We now also have continuous blood sugar monitors, or continuous glucose monitors, CGMs, that are placed on the skin that give us every 5-minute updates, or a patient every 5-minute updates of what their blood sugar level is. Extremely valuable. There are also alarms built in that if their blood sugar level drops too low or gets above their threshold of wanting to be alerted to blood sugar levels that are elevated, it will alert them to that. It can also alert their partner to that, or a parent to that blood sugar level. And so parents with children with type 1 diabetes really like the ability to monitor the blood sugar levels when the kids are away, so they know they're not having a low blood sugar reaction. The pumps and the continuous glucose monitors in recent years are starting to talk to one another. And that's really an exciting development in our ability to manage diabetes. So if the continuous blood sugar sensor sends a signal to the insulin pump that the blood sugar is too high, the pump will start delivering more insulin automatically, either by raising the background amount of insulin or giving a little bolus of insulin. And if it sees that the trajectory is downwards and the blood sugar is going to be low in half an hour, the insulin pump will suspend. This is a major innovation and an improvement in the way that we can manage type 2 diabetes. It's not a cure, but it takes some of the burden off the patient. So if they know that in the background, regardless of what they're doing, the system is constantly adjusting their insulin dosages, that's reassuring to patients. It takes some of the burden off the patients. It's a high burden condition to manage. I was asked also just to briefly discuss diabetes and cancer. And so interestingly enough, cancer rates are higher in people with diabetes, particularly type 2 diabetes. Liver cancer at higher rates, pancreas cancer, endometrial, that is uterine cancer, is at higher rates. And one of the mechanisms is that insulin is a growth factor. So it's thought that high insulin levels that are required when either because of type 2 diabetes, insulin levels are high because of insulin resistance, or when we give insulin to people, their insulin levels are higher than usual in the bloodstream, that can stimulate tumor growth. The other likelier possibility is that when people who have diabetes have increased fat get into the liver and into the pancreas, it causes some degree of inflammation, and inflammation can lead to cancerous changes. And so the good news is some of the medications that we know, such as metformin, are associated with a reduced cancer rate. Those studies haven't been done as well with other diabetes medications that treat insulin resistance, but presumably there might be a reduction in cancer rates with those medications as well. The drugs just haven't been around for decades for us to be able to see that yet. Kelly, we're at a time when I think this might be good to stop. I just have one take-home message, if I may.
Sure.
So number one is that diabetes can be a bad disease, and the diabetes complications are preventable. I mean, if you walk away with nothing else tonight, that's important. And in persons who have diabetes, they should pay attention to it. I think a lot of us, when we have a condition that's not bothering us that much, we kind of ignore it. This is not a diagnosis that you can really ignore, because ignoring the diagnosis will allow blood sugar levels to stay elevated and cause long-term complications that won't be symptomatic until you start having vision loss or kidney failure or heart disease. And because these complications are so preventable, it's good to touch base regularly with your physician, at least on a twice yearly basis. And if you're uncontrolled, every 3 months. And if you have complicated diabetes that is not being well controlled, or if you have type 1 diabetes where the expertise of an endocrinologist be worthwhile, it's worthwhile seeing an endocrinologist or going to a diabetes center like the ones we have at Johns Hopkins, because we have the expertise and we have the supporting staff, the nursing staff, the diabetes educators that are needed to teach patients how to manage their disease. So Kelly, I will close with that.
Great. Thank you so much, Dr. Donner. Wonderful information. Before we get started on some questions, just sort of a general question, and you touched on it a little bit, but has there recently been significant research findings that change the care and diagnosis of diabetes? I know you've mentioned, we don't have a cure, which is really something, right? Considering how long diabetes has been around, like many other diseases. But is there anything that you can speak of that you think is on the real forefront?
So from a type 2 diabetes standpoint, these intestinal hormones that I mentioned, one of which is called GLP-1, there's another one called GIP that is just now coming out. GIP is another hormone that regulates blood sugar and has effects on appetite. So we as physicians love to use things that are physiologic, that are deficient in people with type 2 diabetes, that we can replace and return their physiology back to normal. And so if you have an agent like the ones that are available today, the GLP-1 agonists that regulate appetite and assist with weight loss, that in the last 20 years has been the biggest innovation for our management of type 2 diabetes. And the new ones that are going to combine GLP-1 and GIP are even more effective at lowering blood sugar levels and leading to weight loss. And likely, if you follow people long-term, will also reduce not only diabetes complications, eyes, kidneys, nerves, but also heart disease. So that's a big intervention. Type 1 diabetes, these hybrid closed-loop pumps that I just talked about. And also, I mean, there's a lot of treatments now that are targeting the immune system. These are in the early forms of development that are hoping to turn off the switch that stimulates the immune system to start attacking and destroying insulin-producing cells. That's exciting. And we also, we were one of several sites in North America that did stem cell implants. These are pancreatic stem cells that once you put them under the skin, mature into insulin-producing cells that start producing insulin on their own. And once that delivery mechanism gets better and we can potentially turn off the immune system from attacking those cells, that might be a potential cure in the future. So I'm excited. Patients with type 1 diabetes have been told for 30 years that a cure is right around the corner. So I'm not saying that, but we're doing things from a lot of different directions these days that make it much more hopeful that some innovation that will replace subcutaneous insulin injections is around the corner in the future.
Thank you. So just to clarify for type 2, if you are diagnosed with type 2, are you saying that it is not reversible unless you were doing perhaps this bariatric surgery, as opposed to you hear a lot or people read a lot on the internet, which can be a no-no when it comes to finding out medical information. You really should ask your experts. But if their glucose levels are high and their physician is saying something like, you're leaning towards being a diabetic, right? You're getting there, or you're getting there, and or you're there. Are you saying then there's no way to actually? I'm sorry, that's two questions. One is if you don't have it yet, and you're almost getting, gee, we think you do. That is when you change your diet and you can try to prevent them from getting to the actual diabetes stage. Is that correct?
That's right. So it depends on how far advanced your diabetes or your abnormal blood sugar levels are. Prediabetes means that your body is still doing making a decent amount of insulin for the amount of, if there's any insulin resistance out there, and that lifestyle interventions are very likely to normalize blood sugar levels.
Mhm.
You can do that also with if you have established type 2 diabetes. The earlier the better, so if you've had diabetes for 1, 2, 3, 4 years, if you change your eating habits in a healthier way where you end up eating fewer calories,
Mhm.
exercise more, there are people who can get their blood sugar levels back into the normal range. Over time, the longer you have diabetes, the less well your pancreas functions to make insulin, it becomes more difficult to do that.
I see.
And then you need some more drastic measures, especially if you're on multiple medications and all. It
Right.
takes just something more dramatic or drastic like bariatric surgery before you can get blood sugar levels back into normal range.
Mhm. Very good. Thank you for clarifying that. That's a good reason to keep your diet and exercise and sleep and stress all in moderation, right? Easy to say.
Right.
Easy to say, hard to do, but certainly worth it. So we're going to jump to the questions. We have a question from Ernestine. And the question is, does a thyroidectomy increase the risk of becoming diabetic?
So a thyroidectomy. Thyroid organ is another endocrine gland. The pancreas is an endocrine gland, make insulin. The thyroid is an endocrine gland that makes thyroid hormone. But the two are not linked, actually. So if you've had a thyroidectomy, you will need to be on thyroid hormone so that your thyroid levels stay in the normal range. The only way I could link the two is that if you do not get enough thyroid hormone, or you do stop taking your thyroid pill and your thyroid levels start dropping, you will start getting fatigued and you will start being less active and gain some weight. And that's an indirect way. Maybe you could link the two, but otherwise, if you have a thyroidectomy and take thyroid hormone and get your thyroid levels back in the normal range, you should be at no more risk for diabetes than somebody without a thyroidectomy.
So that would kind of lead into too. So if you have other autoimmune issues,
Mhm.
would the same rule kind of apply? It doesn't necessarily mean then, you're going to become a diabetic because you have another autoimmune issue that's doesn't have anything to do with the pancreas. But
So, yeah,
yeah.
I'm sorry. I didn't
No,
mean
no,
to.
no. Go ahead. Yeah.
No, so that's a great question. So autoimmune diseases, there's a bunch of them, right?
Mhm.
And so if you have one autoimmune disease, you're more likely to have other autoimmune diseases. If you've had one, you're more likely to get others. The good thing is that most autoimmune diseases are uncommon. So if you double an uncommon thing or a rare thing, it's still rare or uncommon. So while you're more likely, let's say 2-3-fold more likely, it's still not likely that you're going to get another autoimmune disease. But we as physicians look for them more carefully. So reversing things, that if you have type 1 diabetes, I will check a thyroid level on my patients once a year
Mhm.
because thyroid autoimmune disease is common. The rest of the autoimmune disease are considerably less common. And so I will do a thyroid blood test once a year to make sure that they don't have the earliest sign of an underactive thyroid, because people don't feel well when their thyroid becomes underactive. So we do that screen. The other thing is if you have any gastrointestinal symptoms, especially diarrhea or bloating, we will do a celiac screen in people, because celiac disease is another autoimmune disease that's, the immune system reacts to gluten in wheat. And so we'll do those kind of screens. But from then on, it's only if they have symptoms suggestive of another autoimmune disease do we screen for it.
Great. Thank you for clarifying that. That's important, because the other question too is about hereditary then. So you have this whole issue about autoimmune. If you had one and you don't, and you just answered that. But what about, hereditary, someone in your family, whether it's your paternal and maternal, sides, or maybe somewhere in your family at some point, would you be considered at a little higher risk?
If they have diabetes.
If your relatives had
Yeah.
diabetes.
So great question. That's one of the major risk factors. So as with many things, genetics play a huge role in the predisposition to diabetes. There are people who are 500 pounds who have completely normal blood sugar levels. So weight is not the only thing. You have to typically have to put weight in somebody who's extra weight in somebody who's genetically predisposed. If you have one parent with type 2 diabetes, you have a 20% chance of developing diabetes. If you have two parents, it's 40%. So it's quite high. If you have type 1 diabetes and your father has the disease, you have a 5% chance. And if your mother has type 1 diabetes, it's about a 3% chance of diabetes. So it's less of a risk, but 3 to 5% is much higher than the general population's risk. So that family history, that's why physicians ask about family history.
Sure.
So it makes us more likely to screen for conditions. Yeah.
Sure. And to also think back, not necessarily just your parents, if you happen to know or can remember, that's also, I would imagine, pretty helpful as well.
Yep. So yeah, grandparents, aunts and uncles, and it's common. Most people with type 1 diabetes, their parents do not have it. But if you look out into the family history, it's not uncommon. If you look into cousins, second cousins, that there's a type 1 diabetes gene there and that they had it. Unfortunately, before 1920 or so, when we started doing testing for blood sugar levels, people died of wasting diseases. They died early in age, and people had no idea that they had diabetes when they died. So we can't go that many generations back. I guess it's 100 years now. So, but we can't go but too much further back than grandparents with respect to, or maybe great grandparents with respect to diabetes.
Sure. Thank you for that. There's a question from Stella. Can late onset diabetes indicate that a patient has pancreatic cancer?
So it can. Fortunately, it's still rare, but it can. So having diabetes puts you at higher risk for pancreatic cancer. We don't fully understand why, but again, fat that's been in the pancreas for a long time can lead to inflammation and potential risk for cancer. If patients present with new onset diabetes at a later age and they're losing weight and their appetite is decreased, that's a flag. That's a constellation. They don't fit the weight gain and that they've been gaining weight, and hence their blood sugar levels are higher. If they're losing weight, if they're thin, they're older in age, then we will start considering screening for pancreatic cancer. But we don't screen everybody with type 2 for pancreatic cancer because that it's not that high a percentage. Boy,
that's tough to diagnose or figure out, I would imagine, because that's just sort of the natural aging process. It can be, where you tend to, you lose your appetite, you tend not to, lose some weight, your muscle mass, and right, and I would imagine that's pretty difficult.
That's right. Yeah.
Yeah.
And, as we age, if we lose weight, a lot of it is muscle weight. And so loss of muscle weight actually can raise blood sugar levels up because muscle is the main organ in the body that takes sugar out of the bloodstream. But weight loss in general will decrease the amount of diabetes medication. So it's not uncommon, actually, as people get older with time, if they lose weight, that their medication requirements go down. With pancreatic cancer, they're losing weight and their medications are increasing because the pancreas is not making enough insulin. The tumor per se doesn't knock out the pancreas, but it is releasing substances that make the pancreas make less insulin.
I see. So Anne would like to know, does the entire pancreas need to be removed to cause diabetes?
So the beautiful thing about endocrine organs is they have a lot of reserve capacity, and you typically have to knock out 80% of a gland for it to become underfunctioning. So people who have thyroid problems, we can take out one side of their thyroid and their thyroid function is completely normal. The same is with the pancreas. It takes about knocking out about 80% of a pancreas function before they have diabetes. And so at Hopkins, we're one of the premier pancreas surgery centers in the world. And they will try to preserve normal pancreas so that patients don't develop diabetes afterwards. And so I commonly see patients who've had a third or a half of their pancreas removed who have completely normal blood sugar levels, or they just have very easy to control diabetes because they have some of their pancreas is functioning normally because it was left behind after the surgery. Amazing,
really amazing. The human body is amazing, right?
Thank goodness.
Thank goodness.
Yep.
Remarkable. Our next question is from Lisa, and she would like to know, should diabetics eliminate all carbs?
So all carbs, it is going to be easier to manage both type 1 and type 2 diabetes with a lower carb diet because you're putting less demands on the need for insulin. So in type 2 diabetes, lower carb diet, don't put as much stress on the pancreas making insulin, blood sugar levels come down. Same with type 1, they need to give less insulin. They have less fluctuations in their blood sugar levels because their carb diet is low. Moderation is the key, as with any diet. Any extreme diet tends not to be well tolerated. Elimination of carbs means you have protein and you have fat, kind of an Atkins-like diet. And many of patients of mine who've tried that have difficulty maintaining that for more than a defined period of time, 6 months, 12 months. They lose weight, their blood sugar levels improve. They say, all right, that's enough. And the weight regain can be rapid after that, and then blood sugar levels follow it. So certainly if you eliminate carbohydrates, blood sugar levels will be better. Be careful, because I am more on the side of the Mediterranean diet, which is higher in fiber, lean meats, and proteins, and less so with a unrestricted no carb diet where you can have as much fat and protein as you like, because fat does have long-term risks with respect to contributing to heart disease years down the road. So we have not studied people for 3, 5, 10 years on a no carb diet, but especially the very high saturated fat diets, I'm a bit worried that might lead to heart disease. We don't have the data, unfortunately. From a blood sugar standpoint, it's how many calories are you taking in, or from a weight loss standpoint, it's how many calories are you taking in and how much weight will you use. Well, if you eat enough fat and protein, you don't want to eat anymore, and so your intake will decrease and you will lose weight. But in my experience, it's hard for patients to sustain that after time. So I think moderation is the key.
Yeah, thank you. Yes, I don't think I could do that. I'd have to do that in moderation. Gotta have a little carbs. Okay, our next question is from Mary, and she would like to know, what is the glycemic index, and how does it help diabetics manage their disease?
Yeah, so glycemic index refers to how much does a carb affect your blood sugar levels. And so there's, you can get anywhere, if there's a glycemic index goes anywhere from 0 to 100. And if it's 100, or if it's very high, a high glycemic index means that there are a lot of simple sugars in that food, very low carbs. And so it basically says, if you eat that, what's your impact on your blood sugar going to be? So a low glycemic food would be lettuce. There's very little in the way of carbs in lettuce. That would be a low glycemic index food. A high glycemic index food would be a popsicle, or a regular soda, because it is pure simple sugar, and it's going to be very rapidly absorbed in your bloodstream. And it will, if you have a sluggish pancreas or no pancreas, it's going to spike your blood sugar levels up very high. If you have no insulin production, it'll spike it very high. So that's a high glycemic index. And so we try to recommend people eat more low glycemic foods. We don't tend to use that term so much when we talk to patients, but we talk to them about moderating the simple sugar content of foods and increasing fiber. If you think about high fiber foods, they tend to impact blood sugar levels less, because the fiber will slow how fast the food can be digested in the stomach. And the slower it takes, or the longer it takes for foods to be digested and delivered to the intestines, the less of a spike in the blood sugar level is going to be. So high fiber, more protein, lower carb are higher or lower glycemic index foods that impact the blood sugar less after you eat them.
Sure, thank you. Greta would like to know, so what is the new nose spray? How does it work?
So there is a spray that came out several years ago that is a form of glucagon. In a diabetic emergency, which means a blood sugar is so low that a patient cannot treat themselves with food or something to drink, typically when they've lost consciousness, it's nice to bring the blood sugar up with something. And glucagon is a hormone that counters the effects of insulin. Glucagon raises blood sugar levels up by telling the liver to dump sugar in the bloodstream. And glucagon historically has been given as an intramuscular injection. So you have to resuspend the glucagon in a vial. You have to stick a needle into the vial. You pull out the glucagon and you give it as an intramuscular injection. Imagine if you are not trained in medicine having to do that for a loved one that you're living with who
Hmm.
has a severe low blood sugar reaction. A glucagon nasal spray is you take the cap off and you inject the spray into the nose, just like you would for a decongestant or a steroid nasal spray. And it's a little bit slower than an intramuscular injection, but by the time somebody finds intramuscular injection, mixes the solution and inject, you're probably having the response at the same time. So this is a glucagon nasal spray that can bring blood sugar levels up in someone and prevent them from having a more severe low blood sugar reaction.
Hmm. Great, thank you. And Rosie would like to know on that follow up of that, what are the signs of low and high blood sugars?
Sure. So low blood sugar symptoms are those of adrenaline, typically. And so if the blood sugar drops below about 70 or so, the earliest symptoms tend to be those of adrenaline. So fast heartbeat, shaky, nervous, anxious, sweaty. And if they get more profoundly low, the next symptoms would be slowed mental processing, confusion, fatigue. And so those are symptoms of low blood sugar. In persons who have type 1 diabetes, they can lose the adrenaline symptoms. The adrenaline symptoms are a red flag, heart palpitations, shaky, my blood sugar is low, I'm going to go treat myself. If I gave you, Kelly, assuming your blood sugars are normal and you're not on insulin, if I gave you a shot of insulin and dropped your blood sugar down, you'd get symptoms at a blood sugar of 70.
Mm-hmm.
If I gave you the same shot of insulin the next day and dropped your blood sugar, you probably wouldn't get symptoms till you're about 65 or 70. I'm sorry, 65 to 60. So you would only get symptoms of lower blood sugar. So one low blood sugar will blunt your recognition of the next low blood sugar. So we have patients with type 1 diabetes who we're trying to control tightly. We're trying to keep them in an 80 to 130 range all the time. And so periodically they're going to get low. So we have many patients who've developed what's called hypoglycemia unawareness, and they can have blood sugars in the 30s and the 40s, which are dangerous, and they may not know it. Their brain is compensated, and their first symptom may be confusion, and that's not the first symptom that you want. And those patients are more at risk for a severe low blood sugar reaction.
Right. So with that, so maybe perhaps for those particular patients, maybe a pump. Now, if you want to explain just for a few minutes, what characteristics are important when selecting a pump and how helpful and useful would this be?
Sure. So as I mentioned to you, pump therapy delivers insulin more physiologically, and we see less in the way of low blood sugar reactions. And if we use something in somebody with type 1 diabetes where they have fewer low blood sugars, especially fewer markedly low blood sugars, their symptoms of a low blood sugar may actually improve. And so unawareness of low blood sugars is one of the reasons that we not only tell patients they should get a continuous glucose monitor, and that's pretty much any type of patient with type 1 diabetes, but definitely if they have unawareness of low blood sugars. And then insulin pump therapy, because insulin pump therapy has been associated with fewer low blood sugar reactions. Mm-hmm. And then the next generation, which have just become available in the last few years, are these hybrid closed loop systems where the pump will actually suspend insulin delivery if the blood sugar is headed low. A perfect patient that should be on such a device, if they don't recognize low blood sugars, if you have a pump suspending insulin delivery, they're much less likely to have a severe low blood sugar reaction. Mm-hmm. So that would be an indication for a pump. Anybody who is challenged to give themselves multiple insulin injections, they forget their pens. The pumps these days also just make it easier to manage diabetes because you can enter in what your blood sugar level is, and you can enter in how much food you're eating, and the pump will tell you you should be taking this many units of insulin. It can give 10th unit increments of insulin, where you can only give 1 unit increments with most insulin injections. So just much better control. We offer pumps to any patient who we're just not controlling well with subcutaneous insulin. We give that as an option. Nice. So there's really no patients that we don't, unless they just don't have the mental capacity. It's technologically more challenging to manage, but most patients are good candidates.
Yeah. And just quickly, we have about a minute or so. Just quickly on for type 1 diabetes, for people who have that, do you lose brain cells when their glucose exceeds 300?
Do you lose brain cells? So the short answer is no. Short excursions of even very high blood sugar levels have not been shown to damage brain cells, which is good. We have found, though, that in both type 1 and in type 2 diabetes, that having very high blood sugar levels over many years can affect the small blood vessels in the
Mhm.
brain. And so
Mhm.
you can get loss of brain cells
Interesting.
because of the small blood vessel disease.
Great. Well, thank you very much. And I'm sorry to have to cut you short, but we're getting close to the 8 o'clock hour. So I would like to take this time to thank Dr. Donner and each of you for joining us this evening. And graciously, Dr. Donner has agreed to respond to any questions that we did not have the time to address this evening. And you'll receive an email with his answers in approximately 2 weeks. In the coming days, a video of tonight's live stream will be available on the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under Videos on Demand. If you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about future programs, conversations, and podcasts, all featuring Johns Hopkins physicians and faculty, and brought to you by A Woman's Journey. In the meantime, we hope you'll find our monthly email informative and engaging. On May 3rd, a special 90-minute program will be held virtually and in person. It is an opportunity to learn about low vision, how artificial intelligence is enhancing CT scans, and the microbiome. If you are interested, please visit our website, hopkinsmedicine.org and /A Woman's Journey. Thank you so much. Good night and stay well.